Thank you for coming to my grand rounds. It's my last presentation, so it's a little bittersweet for me. No, for some reason, the most anxious I've ever been since I started the project like this.
So she'll just be outside and singing.
Yes. So today I will be talking to you guys about depression and CKD. I have no disclosures, so we can just get right on. The objective for this presentation, we're going to discuss how common depression is in CKD, explain the safety of antidepressants in this population, discuss initiating versus not initiating antidepressants in CKD and ESRD population, and how to approach CKD and ESRD patients that have depression. So CKD is associated with a number of neuropsychiatric conditions, and this includes neuropathic pain, sleeping disorders, anxiety, depression, and even though we have various non-pharmaceutical therapies available for this, like lifestyle modifications or cognitive behavioral therapy, when this is ineffective or the disease burden is high, then this is when we should consider pharmaceutical intervention by prescribing antidepressants. In 2013, depression was reported to be present in 20 to 25% of the patients with CKD. It is independently associated with hospitalizations, cardiovascular events, and death. And it's also associated with a lower quality of life, greater symptom burden, sexual dysfunction, not adherence to medications, and not adherence to dietary restrictions. It has also worsened patient-centered outcomes, and depression has been associated with dialysis initiation. In 2016, CKD affected 15% of the US population, and this is 4 times higher when you compare it to the rest of the world. And despite the high prevalence of major depressive disorder in our patient population, there's not enough randomized trials to establish safety and efficacy treatment. CKD patients are usually excluded from the large randomized trials due to safety concerns. So this is a nice chart that I wanted to share with you guys because I feel like it nicely summarizes my topic today. Really, there is a bidirectional relationship between depression and CKD, and there are several behavioral and biological aspects to this. The behavioral aspects, there is an increased burden of self-care related to CKD and ESRD, and this includes frequent clinic visits, frequent hospitalizations. They have specific dietary restrictions, they have increased pill burden, they have to monitor their glucose at home, their blood pressure, their weight, and this can all lead to depression. And then you add the challenges of dialysis, such as traveling to the center 3 times a week, or performing your home chemo or peritoneal dialysis at home. And this is particularly overwhelming for those that don't have a social support, and also in patients that have been recently started on dialysis. So there was an analysis of 160 patients that were recently started on dialysis, and soon after starting dialysis, they developed depression, and this was associated with a high mortality. In terms of the biological aspects, several studies have reported the association between inflammation and depression in chronic illness. So the association is particularly relevant in our CKD population, where we know that all of our patients have high inflammatory levels. And this has been associated with poor health outcome and CKD progression and mortality. Another potential biological mechanism that can lead to depression in CKD and ESRD patients is the effect of cerebrovascular disease, which is highly prevalent in our population. So this can affect mood regulatory functions of the brain and in turn lead to depression. So for example, there have been specific post-stroke lesions in the left inferior and the left basal ganglia and in the close frontal lobe that have been associated with depression. So cerebrovascular disease can also indirectly affect mood by increasing inflammation. And this in turn is the perfect combination for our patients to develop depression. So now I wanted to discuss a few studies, and I wanted to start with this Dutch study. And this Dutch study basically examined chronic antidepressant use in patients with CKD 4/5, patients on dialysis, patients that had a functioning kidney transplant, and they compared it to matched controls from the general population. So the Dutch Health, they have a data, it's called the Vectix data. And since health insurance is mandatory in the Netherlands, 99% of the Dutch residents are insured, and out of that population, 99% of them are included in this data. And the database contains reimbursement data for healthcare products that are covered by the Dutch Health Insurance Act. And it also includes demographic data such as the age, their sex, the postal code, their socioeconomic status. But this data does not include medications that are given during a hospitalization, medications that are given at a nursing home, medications that are over the counter, or medications that are given in an outpatient dialysis center. So they took adults that were 20 years and older that had CKD 4 or 5, not on dialysis, patients on dialysis regardless of what modality, and patients that have a functional kidney transplant, and they identified them and allocated them to a specific group on January 1st of 2017. And if the patients that had CKD 4/5 started dialysis in 2017, or the patient went from dialysis to transplant, or transplant to dialysis, or functioning transplant to dialysis, then those people were excluded from the study. And if there was incomplete data, or the patient died during the study, or if they were unable to match them to a control, then those people were taken out. So then they created a control group for each patient group by randomly selecting 2 controls per patient out of all of the individuals in the Vectix database, provided that they had no CKD-related diagnoses in 2017. And these were matched for age, for sex, and then socioeconomic status. So some of the patient characteristics, so there was actually a total of 4,900 patients with CKD 4/5, 3,800 patients on dialysis, and 8,700 or so patients were with a transplant that were included. And the mean age ranged from 56.5 in the transplant patients to 76.6 in the CKD 4/5. And the percentage of males range from 52.8% in the CKD 4/5 and 59.8% in the transplant patients. And most of the patients were suffering from diabetes as well, and more people suffer from diabetes when compared to controls.
Transplant patients and non-medical patients?
Yes.
So if a transplant patient has GFR classifiable otherwise as 4 or 5, were they placed on the G4, G5, or they were still on the
They were
transplant?
in the functioning transplant. because it's monthly. So the study found comparing the prevalence of depression in CKD 4-5 when matched to a control. The prevalence of depression in the CKD population was about 5.6%. And in the match control, it was 2.8%. And when you look at the dialysis population, the prevalence of depression was 5.3% when you compare it to 3% in the match control. And in the transplant population, depression was present in 4.1% of the patients when compared to 2.7% of the patients. And in both patients and controls, antidepressant prescription was the highest between the ages of 45 to 64, and the lowest in patients and controls ages 20 to 44. And the only exception was the CKD stage 4 and 5, where patient prescription was the lowest in patients that were 75 years of age or older. And in both patients and controls, really you can see that females are prescribed antidepressants more often than males. And in the last status, SES stands for socioeconomic status. The variation in prescription between the socioeconomic status was small.
So come again, so the dialysis, what's the percentage of depression control and versus transplant?
And dialysis or in general?
No, 3.7, I can see it.
At 4.7 in the transplant compared to 2.7.
No, how about in dialysis?
5.3
Okay.
versus 3%. So what type of antidepressants were these people using? So they were mostly on SSRIs, and it ranged from 55.1% in CKD 4-5 to 61.1% in the transplant patients. And the SSRI prescription was consistently lower in patients when you compare it to a control. And citalopram and paroxetine were the most often prescribed SSRIs. And the frequency of tricyclic antidepressants was around 23% for the CKD group, 23% for the dialysis population, and 18.7% for the transplant. And this was significantly higher when you compare it to a control. And amitriptyline was the drug that was most often prescribed in all three groups when you compare it to control. Nortriptyline was most often prescribed for transplant patients, and mirtazapine and venlafaxine were the ones that were most commonly prescribed as other type of antidepressants. So really, in this study, we were able to see the percentage of prescribed antidepressants was higher in the CKD population when they were matched to the general population. Around 6% of CKD stage 4-5, 5% in the dialysis community, and 4% in the transplant community were chronically prescribed antidepressants when you compare it to 3% in control groups. The highest prescription was among patients 45 to 64 years. And in both patients and controls, women were more likely to be prescribed antidepressant medication. It was also comparable across socioeconomic status. So this was suggesting that there is no association between education level and chronic antidepressant prescribing. The SSRIs were the most common prescribed antidepressant, and the TSAs or tricyclic antidepressants were significantly prescribed more often to our patient population when compared to a match. So I wanted to show this study because it varies from the US. In the US, the percentage of Depression is even higher when compared to the Dutch population. So in the Netherlands, 5.6% of their population is reported to have, of their CKD population is reported to have depression. And in the US, 22.4 to 21.8% of patients with CKD 4 and 5 are reported to have depression. So really in the US, this is more common when you compare to the outside.
But I think the difference is this is Netherlands, it's a national health system.
Yes.
Because I'm not seeing a lot of dialysis patients, at least the people we see in evaluation clinic. I don't see a lot of USCSI patients on tricycle funded vessels anymore. I don't know if this is nationalized and it's cheaper for them to do this on a formulary basis. You know, I'm just wondering, yeah.
So now I wanted to change a little bit and discuss a study that was comparing the safety of antidepressant treatment. And this includes drug initiation, the type of antidepressant that is prescribed, and the dose that it was given. And this is only for people with CKD 3 through 5. And these were adults that were at least 18 years of age or older, that were not receiving dialysis between January of 2007 and December of 2019, who had received a diagnosis of depression. And CKD was defined as a one outpatient eGFR measurement of less than 60. And if the patient was already on antidepressants, then a washout period was required of at least 18 months. So patients that were excluded from this study, if they had a one single measurement of an eGFR less than 60, but all the other subsequent measurements were greater than 60, then that patient was taken out. If the patient had a transplant or if they were on dialysis, or if the patient was on multiple antidepressants, then they were excluded from the study. So some of the patient characteristics of this study, most of the patients in this study were 80 years of age. That was the average, the median age. And most of them were, I just thought were married. I wanted to see if there was a difference between being married and single with the lack of support. Maybe a person, you know, who is single, lives alone, maybe they'll be more prone to being depressed. But most of the people in this study were married. And approximately 1,600 of them in the non-initiation group had high blood pressure, and 4,900 of them had high blood pressure in the initiation group. And a higher number of patients had diabetes in the initiation group, around 1,300, when compared to 478 of them. So the study had 3 different target trials, and it had the initiation versus not initiation. They initiated mirtazapine versus sertraline, or initiating sertraline at a low dose when compared to starting sertraline at a high dose or standard dose. So the outcomes, there was a short-term 1-year outcome, and this was looking at hip fracture, gastrointestinal bleeding, and sudden cardiac arrest. And the long-term 5-year outcomes included all-cause mortality, major adverse cardiovascular events, suicidal behavior, and CKD progression. And CKD progression was defined as more than 40% decline in estimated eGFR, or initiating dialysis, or if the patient died and CKD was the primary cause of death. So in this study, there was 7,800 or so individuals that had CKD and depression. And out of those, 5,700 of them started treatment 1,800 of them did not. Out of the ones that started treatment, 1,500 of them started mirtazapine, and almost 4,000 of them started an SSRIs. And among the SSRI initiators, 2,700 of them started a low dose, and 1,200 of them started a standard dose. So this is first a table that shows the association between starting an antidepressant and not starting it. So what were the outcomes? So at the 1 year mark, we see between the non-initiation and initiation group, the incidence rate per 1,000 person in the non-initiation group for hip fracture is 27.1. When you compare it to 33.5 in the initiation group. And when it comes to gastrointestinal bleeding, the incidence rate per 1,000 person in the non-initiation group was 10 compared to 13.6 in the initiation group. And the 5-year outcome, when it comes to death, the incidence rate per 1,000 person in the non-initiation group was 111, and in the initiation group was 114. So it appears that if you start a patient on antidepressants at the 1 year mark, these people have higher rate of hip fracture, higher rate of gastrointestinal bleed. When you look down the line at 5 years, there is really no much difference when it comes to mortality. In this, we are looking at the difference between starting the patient on sertraline compared to starting the patient on mirtazapine. So at the 1 year mark, the incidence rate per 1,000 person of people that developed, for example, gastrointestinal bleeding in the SSRI group was 14.9 compared to 7.8 in the mirtazapine group. In the 5-year outcome, the incidence rate per 1,000 person in the sertraline group was 112 compared to 124 when it came to death. So it looks like starting SSRIs at the 1 year mark gives you a higher incidence of gastrointestinal bleeding when you compare it to mirtazapine, but at the 5-year rate, your mortality rate is higher if you're on mirtazapine compared to sertraline. And this last table is discussing the standard versus lower dose of sertraline and looking at the outcomes. The 1 year outcome, the incidence rate per 1,000 person with a standard dose of sertraline of hip fracture was 39.2 compared to the 32.2 with a lower dose. In regards to gastrointestinal bleeding, the incidence rate per 1,000 person in the standard dose was 19 when compared to the lower dose, which was 13. And when it comes down to CKD progression at the 5-year mark, the incidence rate per 1,000 person of a standard dose of SSRIs was 30.8 when compared to a 24.8 in the lower dose. So it looks like starting a lower dose of sertraline is safer at the 1-year outcome when it comes to hip fracture and gastrointestinal bleeding. And at the 5-year mark, it is also your CKD progression is lower if you are on a lower dose of sertraline.
Yeah, but these are confidence intervals of a hazard ratio, right? So in the last column, you are crossing 0 at both the negative to the positive. So I wonder if that really conveys the message of a significant difference. I don't know if I'm interpreting it right.
I think, I don't think this is because the hazard ratio confidence interval.
Right, it's crossing 0, right? Yeah, so I don't think that's the interpretation is correct.
In the previous slide.
Yeah. Yeah, it's a hazard ratio, so you should, if you cross 0, that's not
So I
convey
think
difference.
The way you present things, you can say there's a trend towards, this. And if it does reach significance, then this is significant. That's the
Okay.
trend versus.
Or there is an absolute numerical equals, but not necessarily statistical.
But are they known to?
They're more likely based on results. All of the studies I found, they might more likely GRD.
What's the big difference between the two lines? Why did you compare mirtazapine and not familiar with that medication?
So I, they're just
That
the.
norepinephrine, what kind of mechanism? Yeah,
Isn't that the one they give to increase appetite?
Yeah.
Yeah.
but this is a mechanism, it's a norepinephrine blocker, what kind of general mechanism?
MAO way.
Is it a molecule?
You need to be careful if patient has a wet lips, then you cannot give it.
Okay.
Time. I know that too late.
That's a molecule. It's a molecule.
So.
So then here's the piece.
Selecting norepinephrine,
Norepinephrine.
the centering you.
Okay, and. Yeah. Norepinephrine. Okay.
So this is just a conclusion. Little table that I found of the study. So basically, starting antidepressants was associated. With a higher risk of hip fracture and a higher risk of upper GI bleed at the 1 year mark, but it was not associated with all-cause mortality or cardiovascular events or a CKD progression over 5 years. And treating with mirtazapine when compared to an SSRI was associated with a lower risk of GI bleed, but associated with a higher risk of mortality. And the SSRI treatment lower dose, starting a lower dose, was associated with a lower risk of adverse drug events and CKD progression when you were comparing it to a standard dose of sertraline. Well, now I wanted to talk about the CKD antidepressant sertraline trial, also known as the CAS trial. And on this study, we are looking at sertraline compared to placebo. And to see if starting sertraline actually improves suppression in patients that are CKD 3 to 5 that are not on dialysis. So this study was a double-blind randomized trial, parallel design. They had 201 patients that were non-dialysis dependent CKD, and they were from 3 different US centers from March of 2010 until November of 2016. And they were screened with the 16-item quick inventory depressive symptomatology self-reported score, and they were deemed eligible if they scored 11 or greater. This particular scale goes from 0 to 27, and the higher your score is, and the more depression you have. And once they established that the person was depressed, they utilized the mini neuropsychiatric interview to establish the diagnosis, but also exclude that the patient didn't have any other psychiatric conditions. And the participants completed a 1-week single blind placebo run-in, and they wanted to exclude patients that were not adherent. And they wanted to make sure that the patients were in fact depressed by making sure they would score 11 or greater in this particular scale. And after they successfully completed the run-in and their depression was confirmed, and they were taking at least 65% or more of the study drug by pill count, they were randomized to starting 50 milligrams of sertraline, and then the matching people were on placebo. And after they randomized the patients, they had to attend clinic visits every 2 weeks for 6 weeks. and then every 3 weeks for the remaining 6 weeks. And the total time of the study was 12 weeks. So the dose of sertraline was increased by 50 milligrams at each visit, and the maximum dose reached was 200 milligrams. And this was based on their tolerability and their response to the drug. And the dose was kept constant for at least 6 weeks of the study. They make sure patients were adherent by counting their pills, and non-adherence was defined by taking less than 80% of the drug. And after 12 weeks, the drug was tapered at a rate of 50 milligrams per week until it was completely discontinued. And after it was discontinued, they were actually reassessed for depression 2 weeks later, and they were offered open label sertraline or other therapy, and that was just managed by their primary care doctor. So the patients had an estimated eGFR of less than 45, and whoever had the following, they were excluded from the study. So if they couldn't give consent, if they had a transplant, if they were on dialysis, if they were actively getting antidepressant treatment, if they were pregnant, suicidal, had psychosis, bipolar, or dementia. So several people will take it out. And the primary outcome of the CAST study, their improvement in depressive symptoms as determined by this particular scale from baseline at weeks 2, 4, 6, 9, and 12. And the secondary outcome included response and remission. And response was graded by more than 50% decrease in baseline from the score. And remission was getting a score of 5 or less. Quality of life endpoints and overall functioning, and adverse events and tolerability. And at every visit, they always make sure to check on the adverse events. So these is some of the characteristics of this study. Do note the N is small. In the sertraline group, we have 97 patients. In the placebo group, we have 96 patients. Most of the patients in this study were male. But we can see at least their CKD was fairly comparable each stage. There was 1 or 2 difference of estimated eGFR among the two. And there was a part of the patients that had diabetes, 58 out of 96 and 55 out of 96 in each group. And a third of them had congestive heart failure, which is, consistent with the type of patients we constantly see in clinic. And at the end of the study, 92% of them completed the study, and they had at least 6 weeks, and 84% of them completed all 12 weeks. And the median duration of the study was 84 days, and the median achieved dose of sertraline was 150 milligrams a day. And the mean percentage of drug taking, and this was done by pill count, in the sertraline group was 94%, and in the placebo group, it was 96%. And then 3 participants in the sertraline group and 2 in the placebo were not adherent. So here in this graph, in the x-axis we have weeks, and the y, this is our scale. So in the scale, it ranges from 0 to 27, and the higher your score, the more severe your depression is. So if you're between 0 to 5, you have normal affect, 6 to 10, you have mild affect, 11 to 15, you have moderate affect, 16 to 20, you have severe depression, 21 or greater, you're severely depressed. So really, we can see that at week 12, when you compare sertraline to placebo, there was not an improvement in symptoms in this particular population when you compare it to placebo. It was almost the same. And these are some of the adverse events that this particular population had. So in the sertraline group, 7 of them started dialysis. In the placebo group, 5 of them did. Almost an equal amount of patients in both groups were hospitalized for a reason other than dialysis. 2 patients in each group had a bleeding episode that required blood. And then 3 patients in each group, the drug had to be stopped because of intolerance. So really, this study shows that sertraline, when compared to placebo, did not improve depressive symptoms in patients with CKD 3 or 4 or 5. And there were some serious adverse events, but it was not higher in patients receiving sertraline versus placebo. But the ones that were on sertraline did have a higher incidence of gastrointestinal side effects. So also the reason why I wanted to show this particular articles is because it's also, there's not a lot of information on our CKD population, but at the same time, when you look at the studies, well, this one is telling me why treat it, doesn't even matter, the scale is the same, and then this one is telling me, well, you can treat it, so it's a little, there's no set guidelines, so it's hard for us to know how to address depression in our patients.
And I think that should be qualified because we're talking of those with a grade 14, so but those with moderate, it does not show difference. The problem is at the higher degree of depression, does it also not have a difference? And you cannot say that, right?
So, as you were presenting, if I was thinking, so they have a common said it's an antidepressant. You're trying to get in CKD to see if it improves depression or not. It sounds silly to me unless you think that there is a biological possibility to say that depression in CKD is different from other. So it might or might not work in this population. I actually went and looked at it online to see whether I'm missing it. It's published in JAMA, so it's really a reasonable paper. It seems that they were looking to see if the adverse events are different, so it should or should not be used, and then they fell on this unexpected result that it doesn't even work in this population, right?
So I guess a little odd.
Yeah.
What scale you use for depression, right? But this is what the patient tells you, there's no actual reason to do it. There's different scales for depression, so it depends on which one you are using. And if the scale is not validated, probably gonna have a difference between the medication. But
No, I don't know what the scales are, but it's published in JAMA. I assume that they have used the scale that is reasonable.
I think that what they're trying to say that the side effects is more than the benefit. Like definitely was worse at the end. They had GI bleeding and GI symptoms without benefit from the depression.
No,
Yeah,
that's
that's what
what
I'm saying, that-
there's no difference in the side effect.
They were trying to see if the side effect is different.
Yeah, but it's
But
not.
then they found that it's actually, so it is kind of unexpected, I would say.
Well, I
It
think,
would be silly to use, so why do you use CKD? With cataract patients, we should use sertraline to see in patients with cataract before, in people with all kinds of diseases. You should have some biological plausibility to say, hey, in this population, I'm not sure this mechanism of action is valid and it's going to work. But there's no such thing in CKD patients with depression. Would you agree?
No.
so that's a good question because certainly it's one of the earlier SSRI, right? So now it extended, is this a class effect or in class ineffectivity or of SRI in the CKD population? It brings up that question. And if that's the case, what is the class of antidepressant that would be working in this population? That's another question.
That's actually what she's going to try to tell
Yeah,
us now.
Very good, yeah. Very good, yeah.
So, okay, so this study, we are comparing cognitive behavioral therapy to sertraline, but these patients are on dialysis. So a little bit different, and they were enrolled between 2015 and 2017, and they were followed until the end of 2017. So this was an open label randomized control trial, and we had 3 different phases. The pre-screening phase, the patients were asked to complete the Beck Depression Inventory Scale to detect the presence of depression. And if they scored greater than 1, then they were asked to be, screened for the study. If they moved on to the screening phase, then they would confirm the diagnosis of depression, and they would exclude active suicidal intent, psychosis, bipolar disorder, alcohol or substance abuse. And then once the person was screened, then they would have to give consent to move on to the treatment phase. And in the treatment phase, it was actually a 12-week process, and there were a total of 180 patients, and they were randomized to either cognitive behavioral therapy at the dialysis center or taking surgery. So these people were at least 21 years or older. They had to be on dialysis for at least 3 months, and they had to meet DSM-4 criteria for depression or dyspnea by using the Lina International Neuropsychiatric Therapy. And several people were excluded from the study if they couldn't give consent, they have active suicidal intent, if they were psychotic, if they had bipolar disorder, they had a transplant, they were excluded, or they were expecting a transplant, they were expecting to receive a transplant, that they were taken out. If they were pregnant or lactating, if they had a history of a GI bleed within the last 3 months, or if they had known hypersensitivity to sertraline. So the primary outcome of this study, it was a change from baseline in depression symptoms and the severity score by using the quick inventory of depressive symptomatology scale, which is the one we were discussing the previous study, goes from 0 to 27. And this was compared to the cognitive behavioral group with the sertraline treated group. So at the 12-week mark of the treatment phase, they were evaluated and they were put in 2 different categories. They either achieved a response by having more than 50% decrease in baseline in their symptoms, or they were achieved remission if they had a score equal or less than 5, or they failed to respond if they had less than 50% decrease in baseline of their depressive symptoms. So the cognitive behavioral group, the participants were scheduled for 10 sessions of 60 minutes each over 12 weeks while they were in the outpatient dialysis center. And the session was conducted face to face. There were 5 different therapists, and each patient saw the same person for all 10 sessions. And the patients self-reported their symptoms by using the QUIT scale every 2 weeks for the first 6 weeks, and then every 3 weeks for the next 6 weeks. In the sertraline group, participants were given 25 milligrams of sertraline, and the dose was increased every 2 weeks for the first 6 weeks, and then the dose was maintained for the last 6 weeks of the study. And they assessed depression using the same QUIT scale.
And they also assessed drug tolerability with the frequency, intensity, and burden of side effects rating scale. And after they started on 25, they went up to 50 the second week. And the goal dose was 200 milligrams unless the person could not tolerate a high dose. So of the 60 people that were assigned to cognitive behavioral therapy, 2 died and 2 withdrew. And the participants completed a median of 5 sessions by 6 weeks and 10 sessions by 12. 80% completed 8 and 73% of them completed all 10 sessions. And of the 60 people that were in the sertraline group, 2 withdrew consent. And at weeks 6 and 12, 78% of them were on sertraline. And the median prescribed dose at weeks 6 and 9 was 150 milligrams. But half of those, they were getting 150 or higher. So the primary outcome, so based on the QUIT scale, when you compare it to baseline, the cognitive behavioral group, the score went from 12.2 to 8.1, so down by 4. And in the sertraline group, the baseline score was 10.9 and it decreased to 5.9, so it decreased by 5. So it appeared that at 12 weeks, the score was lower with the sertraline group when compared to the cognitive behavioral group. And incidentally, there was no change in the score in the people that declined treatment. So it goes a little bit in line with the previous study where giving treatment or not giving treatment didn't make a difference. And this is just a visual representation of what I was saying. So here on the x-axis, we have the weeks and the score on the line. So at 12, we see that the sertraline group, the score was lower than the cognitive behavioral group. And this was some of the side effects that these patients had, and I was highlighting the gastrointestinal side effects because it appeared that all the other studies that I looked at, they always mention gastrointestinal as the most common. And this was the same in this particular study. The people that had gastrointestinal side effects, in the sertraline, there were 22 events when compared to 11 events in the cognitive behavioral therapy, so twice as many GI symptoms.
I have encountered a sign hypothesis why these SSRIs are associated with the GI.
But it's usually nausea, vomiting, diarrhea.
Yeah, that's interesting. Yeah.
Yeah.
I think serotonin.
Oh, the ferocity and the platelet aggregation.
Yeah, based on what I saw, like serotonin binds platelets.
Right, so
there's
if you,
activation.
if you inhibit the uptake of serotonin,
Yes.
so you have more free serotonin.
Right. Which one for platelets?
Serotonin. And that's why you check the hit functionally on the serotonin assay, right?
Hoping for renal
Serotonin.
There you go.
I Google that.
The first years are gonna continue. So this, at the end of this study, we were able to see that based on the patient reported outcomes, the sertraline group had lower scores when compared to the cognitive behavioral group. And the more events happened in the sertraline group when compared to the cognitive behavioral group, and there were mainly GI side effects. So really, to conclude my presentation, we still have a major gap of knowledge in regards to the efficacy and safety of the pharmacological antidepressants that we have for our population. And at the end of the day, just individualized treatment and shared decision making is best. the studies, starting versus not starting, appears that it shows no difference, but if you do start something, then it looks like sertraline is a little bit better than cognitive behavioral therapy. So you can also combine therapies and maybe the patient could be better. But if you do choose to start a pharmacological intervention, then it looks like it's safer to start a low dose and then you can titrate based on their side effects. And if the patient does not improve or if they have really, really bad side effects, then you should just discontinue therapy.